You're listening to Monday Science Podcast, the show that brings you the latest in science, technology, and health with your host, me, Dr Bahijja Raimi-Abraham. Hello, welcome back to Monday Science. Happy Monday, happy day, happy whatever, happy start of the day or start of the episode. Just a reminder that you can connect with us via our website, mondaysciencepodcast.com, where you can also sign up for our newsletter. You can connect with us on social media at @MondayScience_ or at Monday Science, which is on. And you can DM us any questions through our social media, as well as send an email if you wish at info@mondayscience.com. So on to today's episode. Well, let's start off with our Monday Science Person of the Week. And this goes to a former guest on Monday Science, Dr. Zoe Ayres, who is an analytical research and development scientist, but is also a mental health advocate driving for change. Zoe is absolutely amazing. And as I mentioned, she was the guest on the podcast last year, episodes 21 and 22, where we discussed all things academic mental health. The reason why Zoe's getting the award for this week, and to be honest, she'll be getting the award every week, is just really how just is so supportive of trying to drive change around academic mental health, of increasing awareness, being an advocate for change, creating platforms for people to have these very, difficult conversations around academic mental health. All round amazing. So yeah, I just really wanted to honor her today in particular, especially in this time where a lot of people have been struggling with their mental health because of COVID-19 and the impact of the lockdown. And Zoe has been creating content for PhD researchers, postdocs, professional services, scientists, professors, and everybody, and really offering that support. So please do check her out. You can find her website is zjayres.com. And you can also find her on Twitter at ZJayres. On to today's episode. So I read an article in the BMJ. It was published last year, December 11th last year, titled COVID-19. Many poor countries will see almost no vaccine next year, age group warns. So just to give some context, apparently at least 90% of people in 67 low and middle income countries stand little chance of getting vaccinated against COVID-19 in 2021 because wealthy nations have reserved more than they need and developers will not share their intellectual property. Rich countries with only 14% of the world's population have bought up to 53% of the 8 most promising vaccines at the time, which includes all of the Moderna vaccine doses expected to be produced over the next year and 96% of the Pfizer vaccine. In today's episode, I'm speaking with Dr. Mohga Kamal-Yanni, who is a global health and access to medicines consultant who works with the People's Vaccine Alliance. The People's Vaccine Alliance is a coalition of organizations and activists united under a common aim of campaigning for a people's vaccine for COVID-19. Hello, welcome back to Monday Science, and thank you so much for joining us. Today we have the amazing Mohga Kamal-Yanni. Hello, Mohga, how are you?
Hi, thank you.
How are you? Oh, thank you so much, and really grateful to have you on the Monday Science. Sorry. So, do you mind? Let's start off with if you could just tell us a little bit about yourself.
My goodness. So my background, I'm Egyptian. I'm trained doctor, basically GP, and I worked as a GP in my country and in other countries. But then I moved to work on health programs and then health policy in a number of countries, and I joined Oxfam here after going around in many countries, and have been working on the global health policy and programming for many years. Now I'm a freelance consultant, so at the moment I am senior policy advisor for the People's Vaccine Alliance and consultant to UNAIDS.
Amazing. And we're going to be talking more about the People's Vaccine Alliance. And it's really Just so important, and I'm so happy to have you here for the conversation we're about to have. Before we get onto the more serious topics, there's a couple of questions that I like to ask. Firstly, what is your favorite song at the moment?
Wow. Um, my favorite song is an Arabic song, Egyptian song,
Nice,
I'm
yeah.
afraid.
Please tell us, and who's the artist and the name as well.
The artist is a man called Abdul Halim Hafiz. Who, I mean, he's all. I mean, he's dead now, but
Mhm.
his music is really, his songs are really lovely. And the song I love is called, it's called in Arabic, it's called Qari'at al-Fingan, basically the fortune teller, that this lady that looks at your, when you finish your coffee cup, you put it upside down, and then she will read your future. And it's a famous poem about this lady, this fortune teller, who was telling him about his love and the future of his love. It's just a lovely song.
Sounds amazing. Thank you so much. And can you recommend a film or a book for our listeners? Something that you've read, maybe something you've watched, or a documentary that has had an impact or profound effect on you?
Oh my goodness! I tell you what had I mean, what one one book and film. I normally, if I read a book and I love it, it's very difficult for me to watch the film because I think they ruined the book. But
I
the
agree.
one that I felt that it was the film, although the film didn't, it stuck to the book actually. But anyway, it added to it, particularly the scenery. It was A Constant Gardener, which was about some experiments that pharmaceutical companies were doing in Kenya. So the film had fantastic views from Kenya and excellent acting. The book is absolutely brilliant.
Oh,
So, but yeah, these are really low. But they didn't shock me because I work on pharma, so I know what's going on. The one that really shocked me was a video by let me remember her name, a Canadian lady, which is called the shock therapy, the shock therapy.
okay.
I'll find, and
Yeah.
it is about basically what linking the new liberal thinking, you know, with some U.S. people, some what happened in Latin America, what happens in Iraq. It really is incredible.
Amazing recommendations. Thank you so much. I've not heard of either of those books or films, so I'll definitely be looking into that. Thank you so much. So I really wanted to get you on the
Sorry,
podcast.
1 minute, 1 minute. It's called The Shock Doctrine,
The
and
shock doctrine.
it's a book and a video by Naomi Klein.
Amazing. Thank you. Thank you for clarifying. So thank you. Heard about the People's Vaccine Alliance through many different sorts of searches online, wanting to talk about health inequalities on the distribution of COVID-19 vaccine. And so I guess that's really setting the scene for what we're going to talk about today. And so from my understanding of inequalities, it's that it consists of two main components, but please, you're going to correct me because I'm probably wrong. But from my understanding, it's there's the inequalities that occur between groups within the same society and inequalities that occur between nations. So please, could you explain the actual term health inequalities and why in general do health inequalities occur within a society as well as between nations?
You're right. So inequality can happen between any groups or any individuals. There is inequality between men and women. There's inequality between people who have particular illnesses, like people who have were living with HIV, for example. There is inequality between their access to lots of things and other people in the same society. And at the height of the HIV, it was horrible, horrible inequality because of also the stigma, which hopefully is decreasing now. So there is that, there's inequality, there's income inequality between countries and within countries, you know. I mean, you know, here in the UK, there's people who, while you have the billionaires whose wealth has increased tremendously, actually in all the world, not just in the UK. You have people in a rich country like the UK who are dependent on food bank. I mean, that is just incredibly.
I know.
How come if you are a politician? I mean, if I was a politician, I couldn't sleep to feeling that that is happening in my country, in a rich country. I mean, understandable, I guess, in a poor country that some people, it's not good. It's not just. It shouldn't happen. But if you say the country is poor, but here we're not poor here. So it's this is, and it's also that it's globally people are losing their jobs, they're losing their livelihood, they're losing their loved ones, they're losing their breadwinners, and they're losing money. Obviously, that's a majority of the world population, and then you've got a bunch of people who are making more money. I mean, this is just huge inequalities that is a result of, and is leading to huge injustice.
It's really interesting you say that, because I think, I don't know if you have the same opinion, but I feel like 2020 highlighted the inequalities in society, and the fact that, as you said, there are people who've lost their jobs, there are people who've had to turn to food banks. I think there was even a situation where there were the food banks were running out of food because there was so much need. I'd like to discuss because bringing it to focus, I'd like to discuss the historical issue of access to medicines and access to vaccines at a global level. So could you please just give us an explanation, or just why there is this commonality of health inequalities and access to medicines, as well as health inequalities and access to vaccines?
Okay, I don't know where to start. It's a big issue. But one thing is that globally, in all countries, health is not a real priority for countries. The priority is this, I don't know, security, and the economy, whatever, all sorts of things, and then comes health at the end, or with other things at the very end, health, environment, climate, all that. They used to come at the end. Of the priorities, which means at the end of funding. So that's one thing. You can't provide health service on the cheap. This is just a mistake. The other thing is that there is many so funding health service, and then there is the way you look at health. Do you look at health as a right, a human right, and therefore people are citizens entitled to that right? That will lead you to go for things like the NHS in the UK, publicly funded, publicly delivered. That's because we are considered a citizen and have rights. That's of course being dismantled now. Or you look at people as you look at health as, or healthcare as, some goods, so that we are customers. And if we are customers, then you privatize it. Anybody can deliver this good, and it assumes as if we have the choice as consumers. We have the choice, which is rubbish. Because if you have you may have the choice to buy this song or the other, to buy this book or the other, this car or the other, or not to buy them at all. That's a choice. But you don't have a choice as a patient or as somebody who requires healthcare. You don't have a choice of saying, oh, right, I'm going to take that medicine, I'm not that one. Oh, my choice is, I think I have that disease, I'm not that one. Or my choice is that there is this public health measures that the whole country has to have, like a vaccine. A vaccine is not a personal issue, so it's a societal issue. So it's you don't have that. So it can't be used as a healthcare, cannot be provided as a good, as any good. It is a public good, but it's not anything that you can buy and sell. So that's another problem that many countries have. I was actually on a Zoom just a few minutes ago, and there was this professor from the US, and he was talking about the commercialization of healthcare in the US and how they were just, when they faced with COVID, he was talking, even despite Obamacare, there is 31 million people who don't have health insurance. He was saying that millions of people don't have access to primary care. So therefore, because the government decreased funding for primary care, and it's been kind of like looking for all these privatized contracting to companies, they don't have a system of delivering medicine, delivering the vaccine. So it was really scary, the picture there. So that's one thing about why there are inequality of healthcare. So that if you are rich, you can access the best 5-star healthcare, private healthcare if you want. If you are less rich and then you have something like cancer or any other chronic disease or any problem disease like that, you might sell your house in order to cover your costs. So it's which increases the inequality more and more. Come to medicine. So medicines in a way is part of that, but also there is other part of it, which is the setting up of the World Trade Organization and the agreement on intellectual property rights. That the health research has become like dictated by the market. If a company feels like if they produce this medicine or that vaccine, there is a big market for it and they can make money, they will invest in it. If they can, and they can produce it and dictate the price. If there isn't money, money to be made, they wouldn't invest. That's why things like sleeping sickness, malaria, TB, even we don't have really good curative medicines yet, because they just don't make money. Ebola, for that matter, they don't make money, and that's the problem on monopoly on research, monopoly on price, and monopoly on the whole medicine market. When I say medicine, it includes vaccines as well. COVID was like HIV in a sense that before HIV, we knew there was gender violence. We knew there was inequality between men and women. We knew that there's poor people. We knew that people would sleep without food. We knew all these things, but we knew that health service needs a lot of investment, that the medicine needs a way of investment that will produce medicines for people. All that was kind of like common sense, public knowledge everywhere all over the world. What HIV did is got this huge lens and put it on top of that. So nobody can say, oh, we don't know that there's gender violence, for example, gender-based violence. Or we don't know there is not enough medicine for people. COVID did exactly the same. COVID put the big lens on inequality, put a big lens on lack of interest in health system and lack of public funding for health system, and put a big lens on the way medicine and vaccines have been researched and developed. And if you look, and I was following COVID from the beginning, before it got a name even. And I was watching pharmaceutical companies, what they're going to do. Are they going to produce anything? And two things made companies run to do the vaccines. Well, three things really. The first one is that there was already research in universities. So these universities have been funded by the public purse for many, many years. The Oxford vaccine is based on the research they have been doing on SARS. So as we're talking since 2002 and 2003, where they've been researching that. The same with the Pfizer BioNTech vaccine and the others, they're all the same. So that's the first thing. But that's not good enough for the companies. What the market bit of the company is that the governments poured money, literally poured money on companies. The Moderna vaccine was totally funded by the US government. So totally. So they really poured money. So the pharmaceutical companies could see the money. They already got the scientific research from universities. And on top of that, scientists said that this virus is not going to go like SARS. It's actually going to stay with us. And therefore, it's probably going to be like flu. Every year, you will need vaccine. The advantage over the flu vaccine goes to specific people who are at risk. This one will go to everybody because we would need herd immunity. So fantastic market where you can make money. And that's how they went into it. So that's why we have inequality, because governments left decisions about research, supply, production, and price in the hands of pharmaceutical companies.
It's thank you for that overview, Mohga, because it's so, I think working in healthcare, you I mean, I started my healthcare journey as a pharmacist, and I remember at university being very passionate about helping people, and I'm so impassionate, yes. And then I think you then leave the sort of comfort of university, and then you enter real life practice. And then in my case, obviously, you're going down a drug development route and everything, and you then start to realize that healthcare is a business. It is a business to some extent. But and when you were talking about this, the things that people don't realize is the fact that healthcare, unfortunately, tends to be lower down on the priorities, as you highlighted. And it's so it's interesting because health, as they say, health is wealth, right? We need to be alive to do what we need to do in the world and contribute. And and in discussions I've had talking about malaria, actually, and sort of the challenges there as in terms of therapeutics, and the fact that it's just still something that is a burden and an issue globally, is how does one turn the value of health and add sort of an economical twist to it, which is, if you have an unhealthy population, then you have a lower workforce. Is that the way? Because it almost seems as if people don't, or I say people, sorry, I'm sort of saying that in a very callous way, but it almost seems that health and the impact that has on the economy, it seems to be two very separate things. And I don't know whether maybe COVID highlighted that if you have an unhealthy population, then it means people can't work. And I don't know if that's what, I don't know what your thoughts are on that.
Well, yeah, I mean, now politicians are talking about health security. So it did reach the security issue, but whether they would really learn the lessons or not, I don't know, because we didn't learn the lessons from Ebola. And Ebola was a big wake-up call, because when Ebola came, it was clear, oh, these countries don't have a functioning health system. So it's quite clear that health system is an issue. The second thing is, particularly when there was a couple of people who were basically, there was an American who got infected, I think in Liberia, I can't remember, in one of the three countries anyway, and had to go home. And they suddenly realized, oh my God, how do we stop
How
this
do we, yeah,
coming home? And we don't have a vaccine, and we don't have a medicine.
Yeah. And
so, but still, okay, so here's a lesson. Are we going to invest in health system? Not really. We didn't notice a big investment in any country. In fact, we've seen cuts in Britain in the health system. I mean, the NHS is being cut for the last 10 years, and that's one country, one rich country. And we haven't seen any change in the how to research medicine, or how to, look at developing new medicines and new vaccines. And actually, what was developed for Ebola, there was one vaccine. We have a vaccine for Ebola now, and that was developed by universities, funding from the Canadian government. Then it was given to a small biotech, which basically slept on it because they couldn't see a market. And then took a lot, and they couldn't make it, so it took a lot of negotiation to get Merck, a big pharma, to actually make the vaccines. Eventually, we have now a vaccine for Ebola with public money. So
But and this is what people don't realize, and I've spoken about this in previous episodes in the podcast, which is about funding. As a scientist myself, even if I'm passionate about a topic that I see kills millions of people every year, if there isn't any government interest in it, because as you highlighted, universities tend to use public money first as the first port of call to fund their research. If there isn't any interest for the topic, and this was one of the things that frustrated me about 2020 and the pandemic, because there have been people who have been researching pandemics for years, 4 years. There have been, I even, and last year I did like my own literature review, not for publishing, just for my own knowledge. There were people researching pandemics and what to do in intensive care, how to plan for pandemic with children, and how that would, because from what I could read then, they felt that the children may be the most affected, and how do you mobilize them and the treatment. It was just one of the different models. There have been all these bits of research that people are doing, but at the end of the day, pandemic wasn't something that was of interest, or investment was made into. So if you're coming there really passionate and thinking, ooh, looking at the trends and seeing where the world is going, we might have a pandemic at some point, nobody's going to take it seriously because it wasn't a topic of interest that required funding. And of course now everything is all about COVID related funding, which is another interesting conversation. But now it's like, oh, can you pivot your research and to include COVID, because that's the only thing that's getting funded at the moment. And I really like how you highlighted that journey of, and it even made it clearer to me as well, which is universities getting, or researchers are getting funded from public money first, and then having to convince industry to some extent that there is a market for this disease state or whatever it is that you're interested in. And then is it an attractive market? Because as you said, SARS-CoV-1 affected people worldwide, but it I think with SARS-CoV-1 and Ebola, and as you highlighted, yes, there were some cases of people who were affected and then went to America, and it was like, but it just still didn't have the effect that I think people felt with SARS-CoV-1 and MERS and Ebola, that it was a certain kind of person that would get it. So it wasn't made to feel like there were conditions or diseases or infections that anybody could get. And so therefore it's not our problem. It's not going to happen to us. It's not our problem. And even if you remember, we're sort of it was a year ago where the conversations around COVID and some people not taking it seriously, oh, it's just a cough, oh, nothing, it's fine. There were governments initially who weren't taking it seriously at all. And it's interesting how, there's a massive turnaround, but that's because they realized that COVID doesn't discriminate. Everybody and anybody can get it. It actually reminds me, this is a very silly analogy, but it reminds me when I was locuming in a community pharmacy during my PhD, and somebody came into the pharmacy asking for, she was saying that she's going on holiday or whatever. And I was like, oh, okay, cool. And then I said, oh, but you're going to need to get mosquito like anti-malarials and get some insect repellent spray and everything. She said, oh no, darling, I'm going to a 5-star hotel. There won't be mosquitoes there. So I said, I said, no, where you're going, the mosquitoes don't care if you're in a 5-star hotel, they'll find you. So you're going to need, and it was, it's even one of the list of countries where you need to show that you've got to have anti-malarials and everything. And I do really think that people had that attitude about COVID initially. However, the difference is, and if I can really be callous, and I hope I'm not offending anyone when I say this, but in comparison, where certain infections started in countries where, quote unquote, they might expect it to happen. If a disease or infection starts in a remote, or a certain part of Africa or South America, a country in South America, it's a country in Africa, people think it's their problem. And then COVID came and it started, okay, I still don't know if this is necessarily politically correct to say, but the first few cases were highlighted in China. And then because nobody was taking it seriously, it spread across the world. But interestingly enough, the part of the world that was hit the most was the quote unquote unexpected part. I still have hear conversations to date, I think even a couple of weeks ago, where people are like, oh, I'm so surprised how COVID didn't affect Africa, quote unquote, as if Africa is one country. It didn't affect Africa as much, and it's just, I'm probably having a bit of a rant now, but it's just very interesting. And I feel like I've personally, my eyes have been opened to the inequalities because it's just been so blatant. And then now COVID is a priority for everybody, but only because it does actually affect everybody. Nobody is safe from it in that sense. Just because you might stay in a 5-star hotel doesn't mean that you may not be prone
it's
to it.
also because it affects the economy. That's what matters.
Yes.
And if you remember at the
That's
beginning, we were watching the scenes from China.
Yes.
And the lockdown in China, the really serious lockdown in China. And I remember that British Prime Minister saying, well, that happens in China, but here people value their liberty and their freedom and their whatever. And guess what happened after that to us?
Yeah.
So I think, so yeah, so they just looked at it and didn't take it serious at all. Well, China, SARS was in China, but SARS can spread a little bit and then it's gone. So they thought they really didn't take it serious. What are the countries that took it serious? Look at the infection rate and the death rate, the number of infection and death in countries like New Zealand, Germany, Finland, Iceland, Singapore, Taiwan, South Korea, and Vietnam. These are the countries, and also some other countries in East Asia. They took it seriously. In East Asia, because they're used to the time of SARS, they immediately, people know that they have to distance themselves from others, wear a mask or whatever. Test and treat. WHO has been saying test and treat and isolate since March last year, and still Europe, few countries in Europe, like the ones I mentioned, that did test and treat. Actually, the first test was in Germany. Actually the making of the test. The US, they wouldn't use the test that WHO approved, and they decided to make their own test, and then they made a mess of it, and it was just an incredible lack of responsibility. And it was a Chinese virus, and it's staying in China. Well, no, it's not staying in China because viruses don't need passports.
Yeah.
So,
Yeah.
so yeah, it's. I think. I mean, to be honest, it's taking a pandemic that we haven't seen before,
Yeah.
to make us see, or to make decision makers really see, one, the huge inequality and the impact of that. Yes, the virus can infect everybody, but the impact of the virus is not equal. So I am lucky I can work from home, but my family back at home, they can't work from home. They can't isolate themselves and work from home because they have to go to work outside. And if somebody is ill, we don't have the space to actually be isolated. And that's not just in developing countries, by the way, because there are some rich people in developing countries who are living much, much better than me here. But it's also here. There are people here in rich countries like the UK where people can't isolate and don't have the luxury of living at home. What we have here, which is good, is that you get some government support, some support, while in developing countries you don't, or in many, rather in many developing countries you don't. So you have to fend for yourself. So there is that inequality. The lack of interest in health service is quite clear. Are decision makers going to invest in public health after this, when we, breathe a sigh and life goes to what they call it normal? Are we going to look at climate change seriously? Don't know. Are we well, actually, in the middle of it, we're not, and that's why it's again. I don't have much hope, if you like, that decision makers or world leaders will learn, is that they haven't learned in terms of equity in vaccines, in vaccine
Yeah.
distribution.
Yeah.
So at the moment, there is no equity. At the moment, there is no, they're not addressing the fundamental problem of lack of supply. We don't have enough vaccine. We don't have enough doses. So you have to make enough doses. And they still don't want to address that issue because they don't want to touch any of the pharmaceutical companies' monopoly. So as the government pays for the research and development. They're paying to buy the vaccine, and still all they're interested in, like the British want to buy for Britain, the Europeans want to buy for Europe, Canada wants to buy for Canadian citizens. But then you have lots of nice talks about nobody's safe until everybody's safe. I hate this sentence now, actually, because it's so empty. Or vaccine equality or vaccine equity, empty. And then what we got is from the Prime Minister here last week when he talked about donation. And Macron in France also talked about donation. So it's, donation never actually sorted out structural problems like access to medicine. However, even if they donate, because they did make agreements to buy lots and lots of vaccines that are far more than needed in any of these countries. But are they going to donate now? So if you are the Prime Minister of the UK, would you vaccinate the schools so that kids can go to school? Because we have huge mental health problems with young people here because of the lockdowns and all the changes in the school.
Not
And
just
all
young
the,
people. Hand up.
yeah,
Everyone.
yeah, but no, I mean young people about school. So you
Yes,
have this
yes.
thing of let's vaccinate schools so that kids can go quickly. So would he do that, or give the vaccines to, I don't know, health workers in Kenya? Same for France, for anybody. France actually is part of the European Union that is having problems of lack of enough supply. They don't have enough supply. So a company that is producing a vaccine, so they can't produce the millions of doses today or in one day. So they will produce bit by bit. Would they give that bit to these rich countries that are already bought and already paid money, or they're going to give it to poor countries? So we have to avoid that choice. This choice is not the only choice we have. The choice we have is either we live in this situation or we increase supply so everybody can have enough doses. And that's what they don't want.
And what are your thoughts? Because what are your thoughts around in-country manufacture? Because I think part of the challenge as well, and please correct me if I'm wrong, but I do think one of the, and I'm sorry, my reference point is mainly malaria, just because that's my area of research. But one of the things that was highlighted in malaria, but I'm just wondering if it's applicable in general in a wider sense, is that in malaria endemic countries, there is not enough in-country manufacture, so everything has to be imported, and that again ties into the whole challenge of infrastructure, lack of infrastructure, even health systems, and all that stuff. So could some of this be solved if, instead of the need for donation from UK, France, wherever, to the different other countries, quote unquote, I guess, lower middle income countries or developing countries, if those countries were able to actually manufacture their own, then wouldn't that help, because they too are now able to make the vaccine for their own population? What are your thoughts on that, in-country manufacturing and the challenges? Does that also add to the inequalities as well?
Okay, so in-country manufacturing, I mean, even in Europe, not every European country has a huge manufacturing capacity, okay? In North America, America has many companies, Canada has companies, but not to the same extent. So it's not about every country having a big pharmaceutical company, okay, but it's about having hubs. Let's look at what's happening now. So the Oxford vaccine, when Oxford did the deal with AstraZeneca, because Oxford wanted what they call non-exclusive license, which means that basically they license this company AstraZeneca to do the vaccine, but they can also license other companies. However, they were pushed to only give license to AstraZeneca. So only AstraZeneca can produce the vaccine, the Oxford vaccine. However, Oxford, I think I would say, put it like a condition that AstraZeneca makes the vaccine available to developing countries and that the vaccine is sold at no profit price. And to tie that, Oxford said they're not going to have royalties from the sale during the pandemic. So no profit during the pandemic. So that's why the deal with AstraZeneca was better than the others. Now, AstraZeneca, who is not a vaccine company anyway, they went around and, well, the UK government built a plant here in the UK, but they also went around and licensed or had contracts with other companies. So they have a contract with the biggest vaccine manufacturer in India. They have also another contract with a company in Argentina, with a company in South Korea. and I think that some others is just the main ones. So that tells you that this capacity exists.
Right.
Okay.
Right.
Now, actually, we're doing some, colleagues are doing some research about this capacity of companies. So we're looking at what will incentivize these companies to enter the story. They need technology transfer. There is no doubt, particularly for the newest vaccine, because for COVID, there's some vaccines that some technologies that was never used before, like the messenger RNA, which is like the one that's used by Pfizer, Moderna, and then CureVac is coming in. It's not on the market yet. So this is new technology. It seems like an easy technology to produce. It doesn't need like a huge infrastructure to produce it. So they need access to the technology, and they need not to be bothered about intellectual property. So you give them that. Not every company, as I said, we talk about companies that have some capacity to produce. There's some companies that can produce the AstraZeneca vaccine. And we've got the Russians are using the same technology that AstraZeneca, that Oxford has developed. In fact, Oxford is relying on one adenovirus as a carrier. They have a mixture, so it might be, I don't know, more effective.
Yeah, because their effectiveness is like 90-something%, 95% compared to the vaccine.
So there is so there is capacity or potential capacity in other countries. The other thing that you hear is that, oh God, no, building a plant and infrastructure, it takes a year. Fine. If we started last May, we would have had one this May. If we start this March, we will have one next March, even if it takes a year. But if we don't start now, next year we'll be having the same conversation. And with next pandemic, we will have, or outbreak like Ebola, we will have the same conversation. So it's like, would the world learn that investing, every country, the poorest in the world, would they learn that investing in medical research and in research in general is valuable for their own country? And then some countries at least get together and invest in making hubs, manufacturing hubs. So I think that the African Union are talking seriously about, but you've got companies in South Africa, in Egypt, Morocco, Senegal, Ethiopia, possibly Kenya. So, it's about, but you need investment. These companies are not going to create plants and do production and invest in the quality, produce to a high quality without somebody helping them. So,
Yeah, and I think that's
just you said, we've got the government here and governments in rich countries helping universities with research. So we need to do that in a collaborative way as well, between north and south, east and west, south and south, everybody helping so that we have capacity, because at the end of the day, capacity is good for everybody.
100%. Yeah. No, it definitely. Because I want to. This is an amazing conversation. I want to talk a little bit about People's Vaccine Alliance and why it was formed. But beforehand, what is vaccine nationalism? Is that what we've been talking about? Vaccine nationalism? What is that?
Well, vaccine nationalism is when countries basically just looked at what they're vaccinating their population. Right. So the UK, they set up this task force for vaccines, which did deals with all potential vaccines at the time. So that's paying money and making solid agreement. So the company would know that they will be paid that much for the vaccine. They knew that they can produce the vaccine, and if it didn't work, they wouldn't have to write off the cost. It's the government that writing off the cost. So that's, every country did that, and basically scooped a hell of a lot of potential vaccines from the market. So once we have the vaccine, they already solved it.
Very interesting. So could you tell us a little bit about the People's Vaccine Alliance and why it was formed? And also, when it was formed specifically because of COVID or before that?
Yes, it was basically a group of civil society and UNAIDS, the UN agency for HIV. They kind of got together. They were really frustrated. They could see that there is this that there would be a vaccine and there will be a problem with supply, and developing countries might be at the back of the queue. So they got together, and it's co-led by UNAIDS and Oxfam, but it has members like Amnesty International. There's loads of people who are experts or advocates or academics, and there's also loads of NGOs from the north and the south who are part of this alliance. And what they after campaigning to have vaccines, enough vaccines available for people, free at the point of use.
Okay, and so how is that going? Like, what's the progress, that with People's Vaccine Alliance in this agenda?
Well, what we're pushing for sharing technology and sharing intellectual property. The issue is WHO and Costa Rica and 42 other countries last April launched something called COVID Technology Access Pool, CTAP in short. So this CTAP is actually based on another pool called the Medicine Patent Pool for HIV. So it's based on that. So basically it acts as a one-stop shop where companies like Pfizer or AstraZeneca license their technology and their intellectual property to CTAP, and CTAP transfers that license, the IP, the intellectual property, and transfers the technology to the other companies that are willing and capable of producing the vaccines. And then, WHO will, the World Health Organization will look at the quality issues. So we're pushing hard for that, but unfortunately, neither rich countries nor pharmaceutical companies are interested in sharing the technology or intellectual property. So we just keeping pushing for sharing technology, and some of the groups are doing research on the capability in developing countries. Some people doing work on access to vaccine as human rights. And then we're just talking to all these policymakers to promote the idea of sharing. Otherwise, we're just stuck.
Because it's I got shivers actually when you were saying, trying to convince anybody that this is a good idea, that they should share. Surely, and this is where you have to, rightfully or wrongfully, it's a reminder that it's a business. It's a reminder that it's a business. I'm there getting upset thinking, oh my gosh, there are people who won't have access to these medicines. Think about the lives that will be saved. It's really quite sad and it's quite worrying. But then you realize, some people, this is somebody's business. So they're thinking, oh, you've got to convince me that this is a good business idea. Because the other reason why I'm really quite interested in this area and concerned. So I founded the King's College London Fight the Fakes chapter, which is all about challenging and advocacy. I'm interested in infections with our campaign. And so, one of the big things is that obviously if we have a gap in the market in countries that also everybody needs the vaccine. So if we have a gap, especially in poorer countries, this opens up the potential of fake medicines and illegal supply chains. Fake medicines infiltrating supply chains. And so you can have people, fake COVID vaccine, which and it could, the impact that will have in terms of deaths really and whatever other things. So this is one of the reasons why I am concerned, and I think a lot of people are, as to how long can we leave that gap between the countries who have access to the vaccines, the countries who don't have access, because you're increasing the ease for illegal supply of fake medicines or fake COVID-19 vaccines and therapeutics to enter into health systems.
That's a potential problem, of course. Of course, anything expensive or anything unavailable, you will find nice guys who would make a fake one and make a bit of money out of it. Yeah, of course you would. Yeah.
Yeah, I mean, I hope, and so because one of the things that, you know, I guess if, let's say, for example, the Oxford vaccine gets into a country, whatever country, that can't make it, it's also making sure that there are ways to just test the validity of what's arriving, because it could say Oxford vaccine or Pfizer vaccine, but it could also easily just be the packaging, and what's inside could be something fake. So you know, it's anxiety inducing.
Yeah, that's why it has to be publicly delivered, publicly purchased, publicly delivered. The government has to buy the vaccine so they know what they're buying, and they should be delivering it. So as a user, as an ordinary citizen, you know, why should I buy it from the shop when I know I can get it from the government for free, from the government hospital or government health center or whatever? I can get it for free. Why should I go and buy it from somebody else?
And I think
that's selling it.
Yeah.
Then we'll have the issue of buying it.
But you can buy medicines in certain parts of the world. It's not always on prescription. You know, some people, the way in which people obtain and access their medicine is by buying it from a pharmacy, a chemist, or another supplier. So I think people are already assuming they're going to have to buy the vaccine. And you're completely right. Here, nobody's paying for the vaccine. You're getting it as part of the national program. Other parts of the world should be offered the same thing, because and this is where governments can't hoard. They can't, you know, they shouldn't be hoarding the vaccine in a, I don't know, in a room somewhere, not giving it to the people. But anyway, I could talk to you forever about this, and I will definitely have to have you come back. But we're actually coming to the end of the episode, and I just have one more, 2, 3 more questions to ask you, but they'll be short questions, don't worry. So firstly, what challenges, what would you say is the solution to this problem of access to, let's talk specifically about COVID-19 vaccine, access to COVID-19 vaccine globally with no limitations, no inequalities? What would you say is the solution?
Increased supply. Increased supply. This is like, I'm sorry, I keep saying that all the time. You have a small pie and you've got big guys fighting for big share of the small pie. So it's only crumbs that are going to reach the other guys, basically developing countries. So instead of this fight that is useless, really, what about increasing the size of the pie to the maximum possible by allowing everybody who can produce to produce? Whether it's a company in Europe or a company in Asia or a company in Africa or a company in Latin America, anywhere. If they can produce it, let's do that. Fast tracking also the approval of the Chinese and the Russian and others. You know, Cuba is investing in the clinical trials on a vaccine, and Cuba has a good history of making vaccines actually. So looking at these others, because they also can contribute to the big pie, if you like. So big pie is not just Pfizer or AstraZeneca. The big pie is everybody.
Amazing, thank you.
And I think that will, and then everybody takes their fair share. Every government takes their fair share, and every country prioritize the at-risk people. So the vaccine doesn't go to those who can pay; it goes to those who need it. It doesn't go to those who have authority. It goes to those who need it. Brilliant. First, at least, and then it can go to other people.
Brilliant. Thank you so much. And lastly, what would you say would be the take-home messages? What would be the take-home messages that you'd want our listeners to have from everything that we've discussed today?
Push your government to push pharmaceutical companies to share the technology. Push your government as much as you can. Get questions in Parliament if you have that. Get to the media, anywhere that you can reach, even just by telling people, your neighbor, that our government should push for that.
Thanks for joining us this week on the Monday Science podcast. Make sure to visit our website. Details are in the episode description, where you can subscribe to make sure that you never miss the show. So catch up with you next week. Bye.